All right, welcome back to another episode. I'm really excited about this episode because we all worry that we need more patients, right? We need more people in the door. We need to do more. Well, today I have an amazing physician leader, someone who is an expert in coding, but also an expert in just team dynamics, who is going to share with us tips and tricks on why you may not just need more, right? You may actually have all that you need, but you may be undercoding, or you may have opportunity to improve on that process. We're going to spend some time talking about coaching and just team dynamics, because we all know that if the culture is right in the office, everything else flows and works better. So I'm excited to introduce to you today Dr. Hirsch, who is an MD. She teaches medical coding, coaches practice teams on kind of the people side of things, whether that be chart closure or clear MDM habits or front desk scripting. So she's got a huge knowledge base when it comes to operations, but also culture in the workplace. So with that, welcome. Glad to have you.
Thanks so much for having me. I'm kind of going, who is she talking about? Is that me?
That's you. That's you.
It sounds great. Thank you.
Yeah. You've got all kinds of things that you've worked with, and was lucky enough to kind of run into you via LinkedIn. And I've been working with Jill as well on the side. So it's been great to get to know you and your team. So talk to me a little bit about like your clinical career. I mean, what did you practice? How did you end up kind of teaching coding, and talk a little bit about that, and then we'll kind of dive into some of the tips.
Great. So I am an internal medicine physician by training, and I worked in clinical medicine for 32 and a half years, retiring at the end of 2024. During that time, I became kind of a little bit anal, shall we say, about coding, just because I recognize that there's two things you can do in a practice to keep you afloat. One is make more money, and the other is decrease overhead. And we tried to decrease overhead as much as we could, but the other thing we could do is make more money. And by doing, one of two things, either see more patients or do a better job coding the ones that we're already seeing. And so I kind of became a bit of a coding nerd. That's how I describe myself. And I would give coding seminars to my partners in my group. And we would do one on just basic coding, 992, 4, and 5, and then another one on HCC coding, which is kind of my passion. And I just kind of became more and more interested in that. It became kind of more of a career for me when I got into coaching. So I have been involved in the peer review process at my local hospital and for the state of Oregon for the past, 10, 15 years. And since I thought, if I'm going to be on the peer review kind of more disciplinary side of medicine, maybe I should also be on the wellness side of medicine. And so I got involved in our wellness committee. And one of the initiatives that we had at our hospital was a coaching initiative. And there were several didactic sessions. There were several group coaching sessions with a physician coach and several one-on-one coaching sessions with a physician coach. And to a person, everybody liked the one-on-one sessions with the physician coach the best. And I decided at that moment, I have to become a coach. This was back in 2022 during the pandemic. So I got my certification online and did all the stuff. And I've been coaching ever since, more so obviously since I retired. But part of that is what I've recognized in this coding training that I do is when people code correctly, they feel more valued for the work they do. And there's, as you and I both know, there's so much burnout going on right now that when you see people stand a little taller and feel like, hey, that was a 4 and I'm coding a 4, or that was a 5 and I'm coding a 5, and actually do that because they feel confident in what they've done, then it just makes all the difference. And so not only do they make more money, which is, just kind of goes along with it, but they just feel better about themselves. And I think I've seen burnout decrease significantly more than I ever expected as kind of a side effect of this program. So it's been really great.
That's amazing. And I do feel like it obviously when revenue goes up and you're being paid for the work that you're providing, I do agree that people feel this sense of relief and, okay, I can keep doing this. I can do this. Talk to the practices out there that haven't had a coding audit, haven't done any formal coding education. Like, where do people start if, say, they haven't even looked to see if they're coding appropriately? And how often do you recommend people doing this?
I know that things like this can kind of get shoved off to the side because there's many more pressing issues, but ideally looking at things quarterly makes sense. And if you have somebody like a CFO or somebody who can do this, that really makes the most sense. But if not, at least yearly. But I think doing an internal audit, you don't have to spend a lot of money getting an external source to come in and do an audit, although there certainly are those available if you want. And just looking at your distributions, because the problem is because most distributions go, they peak at a 99213. There's many less 99214s and very few 99215s. And literally for most specialties, certainly internal medicine, probably family medicine, it should be peaking at a 4 and many more 5s and hardly any 3s. I remember coding a 3, I would literally have to ask myself, was that really a 3? Am I sure I didn't do something for a 4? And so it's literally looking at that. Now, the problem is if you look at MGMA's standards, they'll say that the code should be peaking at a 3, a few 4s and very few 5s. But that's been skewed artificially low because everybody's afraid to code appropriately because they're afraid of audits. And so that data is really not accurate. So if you compare yourself to that, you've already kind of done yourself a disservice.
And when you guys walk, I know you do coding education and you guys work with practices that say are needing, an audit, and you have a process around doing that. What would you say is the top pitfalls that people are seeing? Are they just afraid, or is it that documentation is missing, or maybe it's a combination of both?
I think there's several things. I think the biggest thing is fear. I think fear-based coding has been the hugest thing I've seen. I worked with a practice the other day, and I said, well, why did you code that a 3? It just felt like a 3. And I was like, are you serious? I just had to laugh at it. She was joking, but that's what she did.
Yeah.
And I think a lot of people, what they do is they perform a level 5 service in the exam room. They document to a level 4 because they just kind of don't know really what phrases they need to get in there to make that documentation stand up for a level 5. And then they code to a level 3 because they're basically scared of an audit, or they just read something in medical economics that says, oh, the big Medicare audit's coming. And so they code a 3 when they've provided a 5 service, and they're leaving $100 to $150 on the table with each visit. And when you do that day after day after day after day, that adds up to a lot of dollars.
Yeah. And I think that I love that description, right? So you did a 5, you document to a 4, and you bill a 3. And have you used in your own practice easy templates that you've put into place, or is it just really spending time with the codes and understanding the nuances, or is there both?
I think there's a little bit of both, but I think the phrases can make a huge difference. So I've developed 3,800 phrases during my 32 and a half years in internal medicine, 3,800. Yeah.
Okay.
Many of them are clinical and related, like what do you do for vertigo, that kind of thing. But the ones that are related to coding specifically, we have about a top 20, 25, 30, and we give those to our clients and basically say, here, have these uploaded. In fact, we'll do it if they don't want to. We'll upload it into their system, whatever EMR they're using, and make sure that those phrases are there. And if they want to tweak them to make it sound like them, that's totally fine. But the basic structure is there, the skeleton, to make sure that you get to code for what you actually did, and make sure that those phrases are there, because that will give you that high octane, coding that'll allow you to code that 4 or 5 when you've actually performed that service.
Yeah, that's huge. And I hear a lot of people get confused over what qualifies. For the MDMs and making sure that the 3s, 4s, and 5s are things that are there. Really, I think it's easier when you've got labs and you've got things that you're reviewing. It's easier to check those marks. But really, when it comes down to what clinical diagnosis really qualifies for that. And I know it has to hit all the 3 sections, or 2 of the 3 sections, but it is hard to kind of get into that pattern of going, okay, no, what did I really do? Making sure I document it, and then knowing and feeling comfortable that you can document or you can build a 4 and the 5, especially because, the payers are sending letters and they're threatening, like, oh, you're using too many modifier 25s, or, you've been billing too many 4s and 5s against your peers. And it is terrifying, but I think if practices get into a habit of, okay, I'm going to annually, check my, do an audit, look at my documentation, look at my billing, make sure that everything's ready, get a refresher in terms of a course or a sit down discussion around education. And then the next piece is looking at those distributions, maybe once every 6 months, once a quarter, if you're a larger practice that has kind of a data guru or CFO that can help you kind of manage that. What do you think?
I completely agree with that. And those letters that you get, I just happily put them in the circular file when I got them, because I know my coding was skewed towards the 4s and 5s. I know it. And I know that I spent that time. And probably 80% of my coding was based on time. And when you do code based on time, nobody can argue with time, number one, especially if you document it appropriately. But number two, I always said to myself, if somebody wants to come from the insurance company and follow me around for an entire day till I'm on the computer at midnight, they are more than welcome to and see that I'm actually coding appropriately, because I'm not trying to game the system. I'm doing what's appropriate. I'm coding appropriately. And to go back to your earlier point, one of the things, this is an example I always give, as an internist, we would frequently see patients maybe for stable hypertension, stable hyperlipidemia, both on medication for both of those things. They come in, we might spend all of 6 minutes in the office. That's a level 4 visit. Boom, done, end of story. You don't have to document a ton of stuff. You don't have to document a ton of medical decision making. You have 2 chronic stable problems. You're on prescription medications for both. That's a level 4 visit, and you spent 6 minutes in the office, maybe 10 minutes by the time you do the note. So, sometimes you're better off based on time. Sometimes you're better off based on medical decision making, but you have to know the rules, because people go, oh, they were just here for a med refill. That's just a level 3. No, that's not. That's a level 4.
What other examples like that do you have? That I just think that's such a helpful example that ties to what people are dealing with every day. Do you have 1 or 2 more of those that just come to mind?
Well, thinking about decisions for hospitalization, for example, or decision for using medication, or decision for ordering labs. If you consider those things and you don't actually do them, you might say, hey, Mrs. Jones, I really think we need to put you in the hospital to manage your heart failure. Otherwise, it's going to be daily labs back and forth. It's going to be really difficult. Oh, no, I need to go home and feed my dog. I get it. They did not want to be hospitalized, but you considered hospitalization. You recommended hospitalization. You told her exactly what to do in the event that XYZ comes up, so that she would know what to do if those symptoms developed. Then that's a consideration for hospitalization. She's got an unstable problem that's chronic, her heart failure, and now you're recommending hospitalization. That's an automatic level 5 right there. And you may not have had to spend a ton of time with her, or you may have, depending.
And making sure that you obviously documented all of those comments, right? That you actually put down that you did discuss hospitalization and what the options were and so forth. So I think that's the important piece, is documenting to the level that you're billing.
Exactly. Making sure that you document that you considered this, you recommended it, and she declined. And the same goes with medications. The same goes with labs that you might want to order. Oh, I don't want to have my blood drawn today. I'm scared of needles. I don't want a chest x-ray. I don't want to get irradiated, whatever it might be. If you document that you recommended those things and the patient declined, that still counts towards your medical decision making.
I love it. So where should practices start when they're doing this? So we've got looking at your distribution, we've got an audit, and then getting some education and training. Is that kind of the 3 buckets? And then obviously implementing those things that you learn.
Right. And then continuing to do regular audits to make sure you're implementing those things. That's one of the things we do with our program, is we come in and we do quarterly trainings, and at 6 months we'll do a mock audit, because we want to make sure that the documentation that we've actually suggested is going to hold up and we have a completely separate auditor kind of do this for us, so that they're very objective and they tell us, are people doing this correctly? Because I think it's important to have that ongoing audit to make sure that you know what you're doing. I personally have also found, and this is maybe a little biased, I admit, but having another physician do the training for 2 other physicians has made all the difference, because we brought many a coder into our practice and we just didn't listen. We just kind of sat there like, And when we bring another physician in to talk to other physicians, because we're all in the trenches together and because we all understand and we can use clinical examples that make a lot of sense, people are riveted. They listen, and we have a great time doing it. So there is, again, I may be a little biased, but there is something to having another physician do the training.
I may be biased as well, because I think the same thing about an RCM company. Like I think having a physician engaged, or as a physician owner, just really understanding the clinical workflows, the operational needs of a practice, and adding that all together to what's going on the revenue side has been really impactful, I think, for our practices. Again, I feel a little biased saying that, but at the same time, it's funny, my team will say, we're struggling with such and such workflow. Can you get on a call? And getting on a call with the practice, and as a physician, walking through the exact same information that the team may have shared, but maybe in a slightly different way or tone related to applying it to the bigger picture or to the clinical need. I just think impacts the practice, and it's been a very it's been a good teamwork between our coding staff and the practices, and being a physician. So I do think there's something to be said about that. I don't know if it's a way about, for physician to physician, or if there's a true reason for it, but I would echo that sentiment.
That's great. No, I totally believe that in the line of work that you do. I could totally see you being more beneficial in terms of being able to make a difference and really explain things in a way that makes clinical sense.
Yeah, it's again, it's a team effort, but it's nice to have that, MD or DO in my case, behind your
Mhm.
name when you are having those situations. So,
Absolutely.
okay, so let's shift gears a little bit. I want to talk about just team culture and how you help practices when there are some team dynamics or coaching that's going on. So, are you doing more one-on-one coaching, like workplace team culture, team coaching? Tell me a little bit about that side of your world.
Thanks. So I've done a little bit of both. Obviously, I started doing coaching during the pandemic, so everything was remote and it was all on Zoom.
Hmm.
But we had some group coaching sessions that way, and that was really great. But these were people from multiple different practices. I haven't gone into many practices to do teamwork so far this at this point in my career. I've mostly done one-on-one coaching, but I would like to expand into that area because oftentimes it's not just one person; it's a team dynamic, and many times it's administrator versus physicians. And if you think about it, we're all on the same team. We all have the same goals in mind. They're looking at outcomes and dollars and all of that, and we're looking at patient care and all of that. But really, the outcomes are the same. We both want the same thing. We just are looking at it from different lenses. And I think sometimes figuring out how to communicate with each other and understand where each person is coming from makes all the difference. So yeah, I've done mostly one-on-one, but I've been trying to get more into doing the team coaching.
Yeah, I think it's important to understand that team dynamics and even just interpersonal relationships in the office make such a big deal in terms of workflows, operational, process, and even revenue to a degree. Because if one piece of that isn't working well, it struggles. It all flows downhill. So, um,
Absolutely.
so talk to me a little bit about one or two tips that you would give maybe a physician who's owns their own practice and they're working through things on their end in terms of trying to figure out how to grow a practice or how to figure out if this is the right place for them still. What are one or two tips that you would have for a physician who's maybe struggling with some of those decisions?
Well, again, I think I would look at, how can you make more money and how can you spend less? And
Yeah.
so on the spending less side, I know one of the things I've been thinking about a lot lately is you get what you tolerate. And I think about where the money is being wasted. I remember at my clinic, we had a scheduler who came in and scheduled for behavioral health people, and they didn't start in the office till 8:30, but she was always there before 7 a.m. And I'm kind of going, why? But nobody had really ever looked at her hours to realize she was punching in an hour and a half or more before her shift really needed to start. So this money that's being kind of leaked out that you don't really realize, the people sitting scrolling on their phones during business hours instead of actually doing work, the high producing physician who's kind of a jerk and who kind of runs the place and nobody's willing or they're too afraid to say something to him because he's a high producer, those kinds of things. The person who comes in late repeatedly and nobody says anything because they've been there for 30 years.
Hmm.
So look at the ways you're losing money without really realizing it, kind of where that money is being leaked out. And then also look at creative ways that you can increase your income. And that could be ancillary services, but honestly, just increasing your coding has we've shown about a $30,000 to $35,000 increase in income per doctor per year just by improving coding. And I think we can do better than that. I think that's just the tip of the iceberg.
And remind me again that that program is at no cost for physicians, correct?
Correct.
It's paid on a percent of revenue increase, correct?
Yeah, it's through a group called Health E Practices. The E is actually an E, based in Lake Oswego, Oregon. And Jill Arena is the CEO of that company. She does a little teaching on what's an RVU and kind of where does the money come from and how does that all work. And then I get on and I do the training for the coding. And our coding program is called Code Mastery, and we offer it completely free. We figure that the proof's in the pudding. So at 3 months, we look at how much increased revenue have we been able to generate for your clinic. Baseline is where we start, and then where we end up. And the difference between those two, we just take a small percentage of that and we continue to do that for a period of a year. And then at the end of a year, we decide, hey, are we going to go for higher hanging fruit? And if we do, we start up the year with a new baseline where you're at right now, and we keep moving up from there. So that's kind of how the program works. We want it to be no upfront risk.
Yeah, and I love that. And I met with Jill last week. Actually, her and I've met several times now. So if folks are listening and are interested in signing up for that program or getting connected with that team, shoot us an email at info@natrevmd.com and just type in their code coding mastery, and we'll get you connected to Jill and Dr. Hirsch's team related to all the coding that can be improved in a practice. And I have to say, having done this long enough, every single practice could use some help. It's just a matter of how far you dig and how wide you educate. So, and it is just an evolving thing, related to making sure that, coding's going well. Any last tips that you have for practices out there who are surviving? And now that you have gone to the other side, you've got obviously lots of projects and other things that you're doing, but you've left true clinical medicine. What advice do you have for listeners?
I would say be sure you document what you do, especially those things you think about and consider. And remember, AI scribes can't get what you're thinking, especially if you don't say them, or even an MA who might be scribing for you. So remember to make sure those things get in your note, because that's going to improve your documentation. Make templates to make that easy for you. All you have to do is click on it and you're there. In fact, I always joke I can't type, so I have everything in my phrases that you could possibly ever want, and then I just highlight and delete because it's much easier for me. So that, and then I think avoid fear-based coding. Remember that you are worth what you do. And even though you may think doing a blood pressure medication is a minor decision, there's a lot that goes into that decision. And you spent a lot of years and a lot of money getting where you are. And it's okay to code for that appropriately. So those are probably the biggest tips.
I love it. I love it. Well, I appreciate our time together today. And if folks do want to contact you for coaching and team culture work, how can they find you?
Probably the easiest way is on LinkedIn. My website is called Physician Coaching with Ann. That's Ann with an E.com. But LinkedIn is probably the easiest and best way.
Okay, great. We'll put your link in the show notes so that folks can find you. And again, it's been great to get to know you over the last couple of months and meet with Jill and the team over there who's doing this coding mastery. So love it. Appreciate what you're doing for physicians, and thanks for spending some time with us today.
Absolutely. Thank you so much for having me on your show. Appreciate it.